Good afternoon and welcome to Second Opinion, Optimal Management of Localized Renal Cell Carcinoma. I'm Dr. Thomas Hutson and I'll be monitoring this meeting today. This is our faculty, Dr. Eric Singer from The Ohio State University and Dr. Ulka Vaishampayan from the University of Michigan. Now, I know when I say Ohio State and University of Michigan, it brings fear into you of some vigorous battle on the gridiron. But I've been assured by both of our esteemed colleagues here that they will leave that type of fisticuffs to the football field and not be here today. So thank you. Here are the relevant faculty disclosures. And for our faculty that will be joining us via video, the consulting faculty, and for commercial support for today, Research to Practice CME Planning Committee, staff and reviewers have no conflicts of interest to disclose. So this program will contain a discussion of non-approved uses of agents and regimens. Please refer to official prescribing information for each product for approved indications. So in order to make this meeting more relevant to participants, Dr. Love conducted video interviews. This is the second opinion component of the program with Drs. Andrew Armstrong, Rana McKay, Robert Motzer, and Sandy Srinivas, during which they were presented questions related to the topics that we all will be discussing today. Excerpts from these interviews will be shown throughout the program, and our faculty will and therefore be providing what we would like to call a second opinion on the topic. This is where we're headed today. Dr. Singer will begin with discussing adjuvant immune checkpoint inhibitors in the management of renal cell carcinoma. I will address the potential role of HIF-2 alpha inhibitors as a component of adjuvant treatment. And Ulka, Dr. Vaishampayan, will finish out the program talking about the tolerability of current and future adjuvant treatments for RCC. So we're going to start here with Module 1, current indications for adjuvant immune checkpoint inhibitors, therapy in the management of renal cell carcinoma with Eric.
Good morning. Thank you to the organizers for the opportunity to be here. And I was asked to start off by talking a bit about how we risk stratify patients for us to be able to have a common terminology or at least a common mindset. What do we mean when we're talking about high-risk kidney cancer? We'll talk a bit about the indications for adjuvant immunotherapy and then also, most importantly, consider our future directions. In terms of scope, I'm not going to be talking about metastatic disease. We're not heavily focused on biomarkers. Not talking about active surveillance, and unfortunately not able to cover every single assessment system out there, but these are certainly the major ones that you've seen and heard, and we're going to try to tackle them chronologically in terms of when they came about. So again, why is risk stratification needed? This talk, in preparing for it, made me think of my mentor, Ed Pellegrino, who is a bioethicist and internist at Georgetown. And he used to talk to us about diagnostic elegance and therapeutic parsimony. So not a sentence that you probably hear much anymore, but again, how do we diagnose the patient properly, timely, using thoughtful tests and imaging, and then match the treatment that we're going to recommend to the problem that they have. And unfortunately, kidney cancer doesn't do very well in this rubric of diagnostic elegance and therapeutic parsimony. Many of the patients who I see in clinic either come in with incidentally found small renal masses, so not super elegant in that diagnosis, or patients who are coming in symptomatic with advanced disease. Again, we've often missed a critical window. So certainly we've got work to do there. And then therapeutic parsimony, these are the choices we have for patients with organ-confined kidney cancer: surveillance, biopsy, ablation, radiation, resection, and then where does the role of systemic therapy fit in to the paradigm for these patients? So this is what we're going to try to address today. So the risk stratification schema really got underway in 2001, and this is the UCLA system, which essentially uses TNM, grade of histology, and then also patient performance status. This is then the Catan nomogram from Memorial Sloan Kettering. They added to the TNM with looking at patient symptoms. Was the patient asymptomatic, meaning incidentally found? Did they have local or systemic symptoms? We then were able to move on to the Mayo stratification system, the S-sign score. Again, TNM. They also included tumor size as a separate measure, which is a little bit unusual to me because we've got size as part of TNM, but then we also included size separately, grade, and necrosis. So necrosis being a different factor than we've seen up till now. We have the Karakowitz nomogram here. Again, they used a larger test set and were able to improve the predictive validity a small amount, about 5%. You'll note they said that they only included things that were readily available on a pathology report, which at that time did not include tumor necrosis, as you saw in the Mayo Clinic schema. This then brings us more into the modern era in 2021 with work from the Fox Chase group representing work done on the ASSURE trial. So this was the ECOG Akron study of adjuvant sunitinib versus sorafenib. You'll note here in the inclusion criteria that this trial included patients with T1B renal cell carcinoma in their trial, which you'll see when we talk about the more current era immunotherapy trials, is not a patient population that was included. So potentially a bit lower risk population than we would see currently. They include patient age at diagnosis, histology. Note that the ASSURE nomogram applies to both clear cell and non-clear cell kidney cancer. Again, looking at tumor size, grade, necrosis, lymph nodes, and then also sarcomatoid or rhabdoid features. I would say that one of the advantages of the ASSURE nomogram is the ease of use, and the folks at Fox Chase have done a great job of having a urology and urologic oncology nomogram webpage. And you can see this here. But please note that the area under the curve, or the C index for the ASSURE nomogram, is limited, and that this has not been an externally validated nomogram. So while it has advantages in that it can be applied to both clear cell and non-clear cell patients, it is limited in terms of how the C index performs. The AUA, of course, we're at the AUA annual meeting here, has also proposed its own risk schema, again, largely based on TNM methodology, and as well as grade of the histology. So I want to shift now and talk about how we are using these schema for patients who we feel are high risk and what we've done in adjuvant trials. This is a table that's looking at trials that used TKIs, so targeted therapies, predominantly VEGF-focused interventions. And you'll see that really the vast majority found no significant difference between the treatment arm with the VEGF inhibitor and the observation arm. The exception to that being S-TRAC, which used adjuvant sunitinib, and this was really the first positive trial in this space. But I have to say that I have never treated anyone with adjuvant sunitinib, and I really don't know of anyone who has really treated anyone with adjuvant sunitinib. And that's because I think the toxicity profile was really unfavorable. You can see here, this is the number of patients who discontinued due to adverse events, 28%. In the sunitinib arm. And then additionally, there were many patients who had to dose reduce. And they found that if you were dose reduced, there really wasn't much of a benefit to be seen. So while Sunitinib may be tolerated in patients with metastatic disease. I don't think it was a good trade-off for patients with just at high risk but no metastatic disease. We then move to the IO era, and this is where things are really getting exciting. You can see this table here talking about Keynote, Emotion, Checkmate, and Prosper RCC, and we'll spend most of our time really focusing on Keynote 564, which used adjuvant pembrolizumab for patients at high risk. You'll note here again that T1B was not included in any of these trials. We're really looking at T2 high grade, so grade 4 or sarcomatoid features, or T3 and T4 disease. Node positivity was allowed, as was M1 NED. But I do want to take a quick detour to talk about Prosper RCC. So this was a fascinating trial in that it was perioperative. So patients received dose of IO prior to surgery and then additional afterwards. So this was a bit of a different concept to use nivolumab in the perioperative setting. Again, T2 and greater, no T1B. And unfortunately, this was a negative study. One of the challenges that we saw with this is that there was some downstaging. So patients who were thought to be clinically T3 ended up being T1A or in the non-high risk factors. This study also allowed for both clear cell and non-clear cell. So a fascinating study design, but unfortunately a negative result. So I'll then touch a bit on really the focus of this, which is adjuvant pembro. And again, T2 high grade or T3, T4, M1, NED, lymph node positivity was allowed. And you can see in the initial report in 2021, seeing an advantage in terms of disease-free survival favoring the pembrolizumab arm. In subsequent 5-year update, you can see that the disease-free survival was maintained favoring pembro. And then overall survival as well. So we've seen not only a recurrence-free or disease-free survival, but also an overall survival in properly selected patients with pembro. In terms of future directions, we clearly want to continue to build on the robustness of our nomograms and our risk prediction algorithms. So Keynote 564, Prosper, LightSpark, which you will hear more about later. How can we develop nomograms using the IO-based therapies like we did for Assure? Certainly, we want to support ongoing clinical trials. Strike, for example, which is an alliance study using adjuvant pembro plus minus the TKI tivozanib for a short course 6-month duration. So combining IO plus VEGF. We know that is a potent combination of metastatic disease. Can we help drive disease-free survival and overall survival by using that doublet in the non-metastatic case? And then, of course, upcoming trials like NeoShift, which is also looking for a perioperative approach. In terms of other things to keep in mind, frailty. How can we strengthen our patients in the perioperative setting to make sure they are most able to handle both surgery and potential systemic therapy afterwards, looking at competing risks, and also importantly, figuring out who is at greatest risk for immune-related adverse events, which Ulka will be talking about later. So not only who is at high risk for recurrence, but who is at high risk for major serious adverse events. That can be important in our decision-making. What I do in my practice, I certainly discuss the possibility of adjuvant therapy for my clinical T2 and T3 patients at the time of initial presentation and discussing surgery, saying we're going to do surgery. There may be an opportunity for us to consider adjuvant therapy. We'll certainly talk more about that. But to begin laying the foundation as that being an option, I discuss the Keynote 564 data, both in terms of recurrence-free survival and overall survival, but also talking about the adverse events. And since Strike is open at our site, I talk about Strike. So really, the options I end up talking with patients about what their post-operative course may look like: surveillance, pembro monotherapy versus clinical trial with pembro, and then the TiVo is randomized. going back to Ed Pellegrino, he also talked about the right and good healing action. So not only something being technically correct, so right, but also good. Is this helping to advance the patient's goals? Is this in line with their values? So I think we have here sort of a patient-centered approach where we're talking about risk of competing mortality, risk of cancer recurrence and mortality, and risk of severe immune-related adverse events, and keeping that patient centered in that discussion so we can come to a really good choice based on what is going to be in their best interests according to their values. Thanks so much for this opportunity to be here this morning.
Great overview, Eric. Thank you. So now we get to our second opinion component and turn it over to Dr. Love.
Good morning, everyone. Our second opinion CME format is designed to optimize the faculty discussion segments of the meeting, and in the last couple of weeks, I met with other investigators in the field for their input on the content focus of this conference. In this case, the recently presented findings of the Phase 3 LIGHTSPARK 022 adjuvant trial, demonstrating a DFS advantage with the combination of pembrolizumab and belzutifan. Doctors Andy Armstrong, Raina McKay, Bob Motzer, and Sandy Srinivas met individually with me to provide comments and questions for the faculty to consider, beginning with Doctors McKay and Srinivas.
The first question is, what are your tools for risk stratification? In the context of Keynote 564, it was largely clinical parameters, pathologic staging and grading that was utilized to identify high-risk individuals. We've seen the revolution of ctDNA in the perioperative bladder space. There's been a movement to look at ctDNA perioperatively in kidney cancer, though I think the disease biology and, quite honestly, the assays themselves are quite variable, where that adds some nuance.
Which risk nomograms are they using? I use the Assure nomogram that looks at not just the tumor size, it looks at risk of necrosis, presence of sarcomatoid, age of the patient, the size of the tumor, the nuclear grade, and it sort of spits out a 5-year disease-free survival, and it also gives you a 5-year overall survival and a sense of if that's 20% versus if it's 60%, I would definitely want to ask them what their threshold is.
So here's a question for us to ponder here on stage here, and I'll ask Ulka and Eric to think about answering that question. Which risk stratification models do you utilize? I think Eric's already mentioned that during his presentation, so let me throw that to Ulka, and then I'll weigh in. So Ulka.
I would tend to agree with Sandy that I clinically, at least in the clinic, when I'm talking to the patient, it is easier to use the Assure nomogram. First of all, it's relatively contemporary. It looked at specifically from an adjuvant trial. Obviously, any nomogram has its limitations, especially in the extreme ends of the spectrum, so really small tumors or really large tumors with sarcomatoid histology, etc. There are fewer proportion of patients within the nomogram. So you have to interpret it correctly, but for the most part, it gives a decent idea for the patients for their informed decision-making about adjuvant therapy.
So, I'll take the perspective that I've kind of been in a hybrid practice for most of my career, that working with U.S. Oncology, Texas Oncology, McKesson. And from a community oncology perspective, I often will ask my colleagues, do you even use a nomogram at all? And when I ask a community oncologist, they generally don't. So the question I'll ask, the follow-up question is, does the urologist who's referring the patient to you give the patient any type of idea? And I see it very mixed, Eric. So your colleagues here at the AUA, if we were going to pull, just a general urologist who's maybe 20% or less of their practice is on cancer, are the patients leaving with a risk from a nomogram, or they're just told simply, go see the oncologist?
I think that really varies on the type of practice. So I recognize my practice is atypical in that it's very kidney focused, and I actually give systemic therapies as well. So I'm counseling these patients and often treating them. I would say that for many of our urologists, it's, we're very used to seeing the scans and seeing the pathology. And so I would say sort of our own gestalt is, I'm worried about this tumor. For me, a small mass that happens to be T3 because of some extracapsular extension is going to be different from a T3 tumor that is going into the renal vein or the IVC, or a stage 3 tumor because of a positive lymph node. So I would say that probably a lot of folks are using their sort of clinical experience, wisdom from that point. And then I think many folks are rightly collaborating with their medical oncology friends to say, hey, this is a patient I'm really concerned about. Sure. I want you to at least have a discussion with them about adjuvant therapy. As you heard, ctDNA, there are several companies in that space who are developing and rolling out trials right now, which we're eager to collaborate with. I think that'll be a great opportunity. And then Assure, again, it's fantastic in the ease of use, but remember, not validated, and the C-index slightly better than flipping a coin. So again, work to do.
Yeah, and so I think that for me, the big take home for practicing physicians is to know that there is adjuvant therapy. I think we're still at that point that most people are accepting that there is adjuvant therapy, refer that patient for that discussion, but they're not necessarily leaving with a percent. I have a 30% risk of recurrence at this point. That becomes more important as we're going to talk about now that we have choices. And we're going to talk about a combination choice, which brings potentially greater efficacy but more toxicity than kind of the standard single agent choice, which has a little bit of toxicity and a concern versus surveillance. So I think as we understand that more, bring in the circulating tumor DNA may be more fruitful to have those discussions. Because in the breast cancer situation, patients commonly leave with a printout, where they have the exact percentage, right? And we're not there yet for us. What about this M1? I think for M1 disease that's resected, that to me is a no-brainer, right? You definitely want to treat with adjuvant therapy, correct?
So I worry about that because I fear, are we really undertreated
yes. Okay.
with monotherapy in that space?
In a resected M1.
And even same with lymph nodes. I mean, we had a paper from a number of years ago that showed that the survival for node-positive RCC that was resected, those patients really behaved much more like a metastatic cohort. AGCC, I believe, is reconsidering staging for kidney cancer coming up. And so it's going to be interesting to see what they do with that. So those are people I certainly would consider extremely high risk. But again, that's where I'm interested in Strike. Are we going to see a benefit of combined IO plus TKI in those very high risk patients? And then also, again, the role of HIF inhibition in combination with IO. And Ulka, I'd love to hear you.
Yeah, and I'm interesting, Ulka, because the hazard ratio for the adjuvant Pembro was great in that. It's like the hazard rate was 0.2. You never see that. So it's an 80% risk reduction or benefit to giving adjuvant in the resected M1 state. But you don't know how long that duration, like, are they hurt by just getting the adjuvant Pembro?
Right.
And they're destined to recur because we undertreated them, like you said.
Yeah.
Is there any study that's really going to answer that question, though?
Currently, there isn't a study that's specifically looking at that subset. What we have to remember is that the number of patients in both Keynote 564 and LightSpark were very small. They were 7 to 8% of the entire population of patients. So when we're drawing conclusions about this patient population, we have to factor that in. I do have a concern that we are undertreating them. Now, with the use of, the combination therapy, potentially, maybe those slow metastases like the adrenal and thyroid, which have been a dilemma for a long time, maybe we end up benefiting them. Clearly, in that patient population or, M1 resected, if they are lung mets, which is the most common, or lymph node, as Eric said, I think a detailed consideration and maybe ctDNA will play a bigger role there in terms of if it is positive, it makes you worry about considering combination therapy to this extent that, So far, small series have shown us that post nephrectomy, doing the ctDNA, if it's positive, there is a much, much higher risk of relapse. ctDNA negative, you can't really interpret one way or the other so far.
Great insight, guys. Let's turn it back over to Neil.
Clearly, LightSpark 022 instantly lit a vigorous discussion concerning clinical application. Here's a tasting menu of the comments and issues raised by Drs. Armstrong and McKay.
The only life-prolonging adjuvant therapy is pembrolizumab in clear cell, high-risk renal cell carcinoma. And I'm interested in the panelists' approach to how they think about whether to intensify beyond pembrolizumab. Some patients don't even accept pembro, Neil. So if you've got T3 only disease, lower grade disease, the risk of recurrence is small, and a whole year of pembrolizumab does have enhanced toxicities. For patients that have resected M1 disease, the risk of recurrence is super high, like more than 50%. And so for an M1 resected patient, that's where I might consider a more intensive approach in these kind of pseudo-adjuvant settings.
If you actually had Pembro-Bel, would you use it? Are there people that you'd only use Pembro in? Are there people that you'd use Pembro-Bel in? Or is Pembro-Bel going to be the de facto new standard? Or are you going to need to wait for overall survival before you make any decision? In the adjuvant setting, it's actually one of the most complicated discussions to have because there's no right or wrong answer. A lot of it is based off of patient values and choice and the things that matter for individuals.
Yeah, so for our faculty here, just continuing on this discussion here, as mentioned by Dr. Armstrong and Dr. McKay, how do we actually deploy this in the setting in real time in our clinics, observation versus single agent pembrolizumab versus the combination? And this is new. We're seeing this emerge today. So Ulka, how are you unpacking this to your patients? And that goes into the next question.
Yeah.
Are you discussing all three of them?
So currently, Pembro-Bel is not FDA approved. But, if it does get FDA approval, I think all three will be very reasonable options. And my approach to it is really having a patient discussion in detail about the pros and cons of the situation. Clearly, if they're higher risk, if they have sarcomatoid histology, going with immunotherapy seems to make sense. And again, this is assuming the clinical factors of the patient and their overall, life expectancy as well as comorbidities are not too bad that they can qualify for any of these therapies. But I think I would incorporate the combination also in the discussion because it has shown improved efficacy over adjuvant pembrolizumab, which was already a higher bar, I thought.
So, Eric, what are your thoughts?
I agree with Ulka. I mean, I don't really get into Pembro-Bel very much just because it's not yet approved. As I mentioned in my slide, I talk about the observation, Pembro, and then clinical trial. So Brad McGregor's Strike trial through Alliance in terms of Pembro plus minus TiVo. I like it in that everyone receives Pembro. So everyone is getting standard of care. And then we're adding in a short course of the TKI. So for me, in my practice, I do observation Pembro and then trial as the option.
Excellent. And, being one of the physicians, being fortunate enough to be someone who does a lot of CME talks, I get to interact with community oncologists. And I'll tell you guys that one of the things I'm starting to hear now is people are concerned about choosing adjuvant therapy, looking past adjuvant therapy, because the community itself, we have not defined what progression looks like and resistance looks like to adjuvant therapy. So I've heard some doctors a little bit concerned, again, about this under-treatment component that, hey, they have a high-risk patient and they've now used two of our big guns, a HIF-alpha inhibitor and a checkpoint inhibitor. They feel that the patient's recurred, say, 6 months after treatment. Does that now limit them in their choice of metastatic treatment options? And so I think that's a problem for our field. We haven't defined yet, right, what progression looks like after these agents. You agree?
Yeah, I mean, I think if you think back, the era of IL-2 was maybe tic-tac-toe. Now we've got VEGF, which is checkers, and now in the IO era, we're playing chess. So we need to be thinking of not only now, but a few moves ahead, because patients are very likely to be able to see several lines of therapy. And so, like you said, how does the sequencing, not only of initial line, but subsequent line therapy play into that?
Ulka, are you aware of any, you lead the cooperative group efforts of SWOG for kidney. Are you aware of any of the cooperative groups' attempts at trying to understand and define progression?
I think there are multiple efforts ongoing in that regard in trying to also risk profile with biomarker panels, et cetera, in both the adjuvant studies. The Assure nomogram is one product of that, but also there are, SWOG recently completed a study called Everest, which looked at adjuvant everolimus, did not show a benefit, but we can learn a whole lot from how these patients are relapsing. I would add, however, that, I know we are worried and we have to strategize for the metastatic disease therapy, but at the same time, a relapse, no matter what shape or form it takes, is an extremely traumatic situation for the patients. So you have to factor in that psychological component when you're discussing adjuvant therapy.
Great. So moving forward here with our agenda, Module 2, we're going to look at the role of hypoxia-inducing factor 2 alpha inhibitors as a component of adjuvant treatment. And I have the honor of speaking at this module. The topics we're going to discuss are the biological rationale for using HIF-2 alpha targeting in patients, a unique mechanism of action of belzutifan as a refresher. We're going to review the outcomes that we've achieved in belzutifan as it's been approved for the use in the von Hippel-Lindau syndrome initially, approved for the use in the refractory setting, and most recently positive data that suggests it may be approved for use in the adjuvant setting. And this comes up to this third bullet point. Is this just oncologists throwing two things together and hoping it sticks, or is there actually a synergy that we can theorize that may occur by the blockade of PD-1 and HIF alpha? And then end with an overview of the recently presented findings from the phase 3 LightSpark 022 trial of the combination in patients with high-risk RCC, and attempt to do this in 10 minutes. So let's see if we can go. So this is a nice cartoon. We've seen this cartoon before, showing us the rationale for targeting VHL. And down the VHL pathway, kind of the end-all product is an accumulation of VEGF, PDGF, c-KIT, and other things that are involved in tumorigenesis and angiogenesis. And we've shown proof of concept that indeed targeting those end factors can produce benefit and outcome in kidney cancer. Well, if you remember your VHL mutation being the most common genetic abnormality associated with both hereditary and sporadic kidney cancer, the step down from VHL loss of function is accumulation of HIF. So it makes, if we can target downstream VEGF, it just makes sense to develop HIF inhibitors, see whether we can get more activity there. So the rationale there is set, and I think proof of concept has been shown. So the first study that really defined that indeed targeting HIF can have dramatic effects was in the VHL syndrome. And Eric Jonas, I know that's been a topic of him and a labor of his love for quite some time. This is pictures from the New England Journal of Medicine, where he was able to show on both the swimmer's plot and then the regular spider plot that RCC can show reduction with a response rate of 49% in patients that receive a HIF alpha inhibitor in patients with germline VHL disease, in a 24-month radiographic progression-free survival of 96%. But also, remember, VHL syndrome is a collection of tumors, not just kidney cancer. If you look at pancreatic lesions, hemangioblastomas in the brain and retinal area, you can see they're listed 77%, 30%, and 100% response rates in those areas. So clearly, the targeting of HIF alpha in VHL was positively affected, and this was a major improvement in outcome for the VHL syndrome patients. And based on its activity in kidney cancer and clear cell, it made sense for us to look at that in the refractory setting. So kind of spontaneously, really done it simultaneously with the study in VHL syndrome, was looking at patients with sporadic clear cell kidney cancer. So this trial schema is shown here. This was studied particularly in the refractory setting after disease progression on 1 to 3 prior systemic therapies that had to include at least a checkpoint inhibitor and a VEGF inhibitor. And patients were randomized into a 1-to-1 to receive the belzutifan at the FDA-approved 120 milligram orally daily dose versus everolimus. And people may say, why everolimus? But remember, when this trial was designed and conducted 5 years ago, everolimus was an appropriate comparator arm in the refractory setting. Patients were stratified by IMDC risk and the number of prior therapies. Dual primary endpoints included PFS and overall survival. And then their secondary endpoints shown are response rate and duration of response. And so if we look at the Kaplan-Meier PFS curves, you can see that clearly over the entirety with landmarks at 12-month and 24-month, there's clear separation of the curves that remain throughout the duration of the follow-up period here with hazard ratio of 0.75. Although the median PFS looks to be similar between both arms, you can see the separation of the curves, so we would expect that maybe to change with longer-term follow-up. I want to call your attention to over at the 3-month side. You see a little blip there, and I think what we see in that and this crossing over that occurs at 6 months really speaks to us, and we've learned this clinically with belzutifan. The HIF-alpha inhibitors seem to take a little bit of time to work. There actually is more of a stable period of disease before you see tumor shrinkage from this, and we come to expect that. So when we start thinking about when should we use a belzutifan type drug, HIF-alpha inhibitor, when should we use a VEGF inhibitor, some of that decision making may be on how fast you need a response based on clues from this particular trial. So if we look at response rate and duration of response, again, 22.7% of patients having RECIST-defined response versus just 3.5% there. There was a complete response observed in this clinical trial with the bulk of patients having essentially stable disease. So if you add up CR, PR, and stable disease, you're getting to around that 60-70% range. Okay, so the next step then, so we clearly showed benefit in belzutifan, a HIF-alpha inhibitor, first in class, novel mechanism of action, was welcomed into our panoply of treatment options for the refractory setting and got incorporated into the NCCN guidelines. So the next step was, well, is there a possible benefit of synergy of combining multiple inhibitors of that VHL pathway? So inhibiting downstream VEGF, PDGF, and hitting at the HIF-alpha level. And so this was the focus of this clinical trial in the refractory setting, which was comparing against a modern, commonly used, if not the most commonly used agent in the second-line setting for refractory disease, cabozantinib. So patients needed less than 2 prior systemic therapies, had to have clear cell progression after PD-1 inhibitor, and prior VEGF TKI was permitted, randomized to belzutifan at the 120 milligram, again, which is full dose of the agent, plus full dose of lenvatinib, 20 milligrams orally daily. Again, suggesting they can both be giving at full dose. That's great. So easily combinable agent versus cabozantinib at its FDA-approved dose as a single agent, which is 60 milligrams orally daily, stratified by IMDC prognostic factors, line of treatment, geographic region, dual primary endpoints, PFS, and overall survival. Secondary endpoints were response rate, duration of response. And there was an exploratory endpoint on time to deterioration, I guess trying to hint at some quality of life things in patients and how they progress. So this is the Kaplan-Meier progression-free survival curves, showing here that there is a separation that occurs about 5 months in favor of the combination therapy and remains separated throughout the duration. The landmarks 12 and 24 months are shown. Hazard ratio 0.70. You're gaining about 4.1 months in PFS in the combination therapy, which was highly statistically significant. And when it comes down to breakdown on actual response rate, RECIST-defined response, we see an additive benefit of the belzutifan lenvatinib of response rate of 52.6% compared to 40.2% with cabozantinib. So difference of about 12.4%. And we see a greater percentage of CR rate, PR rate, and stable disease rate. And the bar graphs there kind of visually show us that difference there. So there is an additive benefit over what we would be considered as a standard second-line, third-line treatment in the refractory. So one gains greater efficacy. Big question then is, right, what's the tolerability? Greater efficacy, is it worth the addition there? This is duration of response. The duration of response seems to be greater when one combines them. and this is overall survival. Overall survival can be challenging, but what one sees here is a hint of survival benefit with a hazard ratio 0.85, a 15% improvement in survival, but the p-value is 0.06. So we're going to talk a little bit later. I know Ulka is going to talk about some of the side effect issues, and she'll touch on those. But one of the concerns, as always, is sequential use of single agents better than combining. Is it worth that added benefit you get? Is it worth it from the toxicity standpoint? So moving into the next question is, well, what about taking a HIF-alpha inhibitor and adding it to a checkpoint inhibitor? And this has relevance as we talk now in the adjuvant setting. Is there a proposed synergy? Can we, as scientists, because we're both clinician and scientists, can we come up with a proposed rationale for this? And the answer is, yeah. We know that as you target the VHL pathway, that it can have immunomodulatory effects. We know that can reduce myeloid-derived suppressor cells. We've shown that with VEGF targeting. So there is some ability to impact the immune microenvironment that may make a checkpoint inhibitor more favorable. And then we know through checkpoint inhibition that can restore T cell activation, enhance anti-tumor immunity. So just from that alone, there is a potential additive or synergistic mechanism. And the proposed ones are enhanced T cell infiltration, reduced immunosuppression, improved tumor microenvironment, and then hitting these complementary pathways. Okay, well, it's the proof. The proof is in the trial, right? And so this is the trial that was recently presented by Dr. Choueiri at the 2026 ASCO GU, and we've alluded to this already. This was a adjuvant pembro belzutifan trial. Patients need to start this therapy within 3 months or 12 weeks from the surgery, and one of the following needed to be met. They needed to be intermediate high risk, as defined there, or high risk, or M1 NED. So it's really that similar enrollment criteria that the single agent pembro trial utilized. They had a median follow-up of 28.4 months. Patients were randomized. This was a large trial of over 1,800 patients into the pembro 400 milligram every 6 week. So they chose the 6-week administration for 1 year, which is 9 cycles, plus the oral standard single agent dose of belzutifan 120 milligrams for 1 year versus pembro 400 milligrams every 6 weeks, 9 cycles or 1 year, plus a matched placebo. So it was a placebo-controlled trial. We don't see a lot of those. The original pembro adjuvant trial was placebo using saline. Primary endpoint, disease-free survival. Secondary endpoint was overall survival. And then there were some other secondary endpoints like safety. Patients were randomized by intermediate high versus M1 NED, as well as tumor grade. When one looks at patient demographics, one would expect it to be balanced because it is a phase 3 trial. And indeed, it is across the line. And you can look down that the majority of patients enrolling on this trial were in that intermediate to high, similar, if not more so, in this trial than in the original adjuvant pembro single agent trial. There were small components of the high or M1 NED. Sarcomatoid features were absent in the majority of folks, but it was included. And then the PD-L1 status is shown there. But again, in kidney cancer, we haven't really used that as a reason not to treat with a checkpoint inhibitor. This is our Kaplan-Meier on disease-free survival here. You can see separation of the curves that occur at 3 months and remain maintained throughout with a hazard ratio of 0.72, so 28% improvement, a p-value that's statistically significant. This is our graph looking at any subgroup, our forced plot here, and we see that there's really, when it comes to normal demographics, nothing that doesn't favor the combination. Although when you get into the risk categories, man, the high and the M1 NED, small numbers of patients, you really can't say a lot, but boy, those confidence intervals go right across. That brings us, and Ulka will talk about this, and we'll talk about this later about, does that influence us at all? Is the data strong enough to support its use there? And this is interim overall survival. It's going to take us a while. The p-value is not statistically significant, but based on hazard ratio, one hopes that eventually with longer follow-up, we may see some benefit in survival, but we can't really call that at this point. So in summary, pembro plus belzutifan showed a statistically significant and clinically meaningful improvement in disease-free survival versus monotherapy in patients at risk of recurrence. It was generally consistent across pre-specified subgroups with the caveat of the confidence interval crossing. Additional follow-up, which is that overall survival, is lacking here. We'll have to see what happens there. The safety profile, which we haven't gone, but Ulka is going to go through with you, was manageable with the low rate, but there was additional side effects. And are these additional side effects worth the efficacy benefit? It's the first adjuvant phase 3 trial to show a benefit of combination therapy over just a single agent active immunotherapy combination. And certainly it supports the application for approval, but we need to know more about it to see how that's going to drive clinical care. So with that part of my presentation, I'd like to turn it back over to Neil.
Given Dr. Motzer's long leadership role in the RCC clinical research landscape, I was particularly interested in his take on LightSpark 022.
The trial was positive, strongly positive, I'd say. So, the real question is, since there's more side effects with the two, is the pain worth the gain, basically, in terms of the additional side effects for the belzutifan to pembrolizumab worth a benefit in disease-free survival? There's people on both sides for that. I was very much involved in the study. We treated about 40 patients. Most of them were my own patients. And, I found that the belzutifan, while it adds anemia in general, it's pretty well tolerated to patients. So I favor the use of this program as an option for standard of care. Now, I do think that adjuvant therapy it's a careful discussion between the patient and the physician for benefits versus risk of side effects. Many of the patients, following nephrectomy are disease-free. They don't have microscopic disease, probably about half. So those 50% of people are, exposed to side effects basically unnecessarily. The problem is we really don't have a crystal ball to look to see, who's going to relapse. And that's where the whole role of the adjuvant therapy comes in. To patients, anemia is a big thing. So I think it will almost be a 3-tier discussion now for either surveillance, pembro alone, or going with the big gun, which is pembro plus belzutifan. And I think for the most part, in my practice, I would be recommending the combination if patients decide on that, but there may be some patients that back away from the additional side effects.
Great. So, okay, so questions for our faculty here to think about. Let's start with Eric. What clinical scenarios do you typically recommend observation for patients with RCC following nephrectomy? And then just to follow up with the second question there is, when do you typically recommend adjuvant pembro? I know we kind of touched on that earlier, but if you can just redefine that for us.
Yeah, so I make a point of discussing it with everyone. I never feel like I want a patient to leave the office and then say, hey, how come I wasn't made aware of this option? So I would say I discuss it with everyone. In terms of those who I recommend it, larger tumors, sarcomatoid is certainly a trigger for me.
Yeah.
The IVC thrombus, renal vein thrombus, certainly lymph nodes. So again, the really quite higher risk. I would say that I have, again, some patients who really want to maximally reduce risk. And in that case, they would be very keen on an adjuvant therapy. At the same time, I have other people, like Dr. Motzer said, there's a known risk. We will be overtreating some people. And for them, the time toxicity, the financial toxicity, the other things of doing a systemic therapy for a year is just not congruent with their values, and that's fine. And so they're going to be getting that close surveillance as well. So I really think, like what Dr. Motzer mentioned, making sure that we're really understanding the patient goals and values piece of it.
Great. And Ulka, we mentioned a little bit about how we're all concerned about the populations that have the greatest benefit are the populations that we think we could undertreat. We don't have the ability to use anything else in that setting yet. We don't have the ability to use belzutifan in that setting yet. Are you not, it's a double negative there, are you not treating these patients?
No, I think I would offer the therapy, the combination even once it's available for those patients. To add to Eric's discussion, I think the patient characteristics also supersede our discussion, in terms of what active cardiac issues they have. If they have anemia already or have end-stage renal disease or pretty close, chronic kidney dysfunction, with their EPO levels being impacted. Those may be things that I would factor in addition to the risk from the tumor characteristics, of course. So I think it's a mix, and the patient age does play a role, which again is factored into the Assure nomogram. So I use that with that patient age factor also. For a 40-year-old versus an 80-year-old, your discussion may be different, the threshold, even for the same type of cancer. Clearly, sarcomatoid, I agree with you, Eric, that, consideration of immune checkpoint therapy is a big deal. Definitely a good staging workup before you start any adjuvant therapy is critical to make sure that the patient is not metastatic. Maybe novel imaging will help us, sort of risk profile those patients better and better to detecting early metastases, so we're not undertreating some of these patients.
Yeah, so I guess I have two questions for clinical relevance. One of them is time to starting adjuvant therapy. This comes up in clinical, in the real world, I'll say, in the non-academic setting. If you're going to follow the clinical trial eligibility, it generally was within 3 months of nephrectomy. Do you have anyone, is that ever an issue for you when people come in and they're 5 months out does that play into any of that? And the other thing is with belzutifan, it's not approved yet. Do we think if we could wear our little hat or have our crystal ball and figure out, do we think the agency is going to approve belzutifan without survival data? Or since this is now combination therapy, which, they've approved single agent Pembro without survival data, people said that they would wait. Will either of you hesitate to use belzutifan without showing a survival benefit? So those two kind of points there. When do you need to start it by 3 months? And would you use belzutifan without survival?
Yeah, so the 3 month is somewhat arbitrary. I think, 4 or 5 months may be okay. A year may be too long. So somewhere you draw the line and say, now your risk of relapse is way lower because you've already been through the period of high risk, for instance, and have not relapsed. So I may not offer if it's pretty late into the adjuvant setting. The other sort of precedent in terms of reflecting whether the combination should be approved, I'll just give the precedent of STRAC trial, where sunitinib adjuvantly also showed relapse-free survival benefit, but not overall survival benefit. And clearly, in terms of adverse events and side effects, belzutifan has a more favorable toxicity profile than sunitinib. And despite the FDA approval of adjuvant sunitinib, clearly we did not adopt it in the clinic, whether academic centers or real-world community centers sort of jointly did not accept that level of toxicity. So I think it's likely to get FDA approval based on current data. Clearly, overall survival would really be, something that would make it easier to have this discussion, because there is that long-term patterns of relapse and et cetera benefit that you see. But understanding the good news is that we've reduce this disease to a relatively longer term chronic disease, and maybe, you would need longer term follow-up to see that overall survival benefit.
Okay, I'll allow you you hedged a little bit, but Eric, let's see what you have to say.
Wow. All right. Being pushed. I like it. So I will go out and say that it will be approved, but I think for me, since we have a drug that we have recurrence-free survival and overall survival, I think it'll be approved, but I don't know if I would yet adopt it until I can say, yes, we have an OS as well. So that's something I'm going to have to wrestle with a bit more to say, yes, it met its primary endpoint, therefore I suspect it will be approved. As Ulka said, there's lots of precedent for that, but would it actually change my practice prior to be able to say, this is an overall survival benefit? Because we know we have that with Pembro.
And I guess to follow up before we move on to the next component is the big elephant in the room for me is, again, we've already decided we really don't know as a field how to define progression on a checkpoint inhibitor and how that can potentially impact and muddy the waters as we think of first-line metastatic. Now we're taking an agent which is involved in a lot of trials right now in combination in the frontline setting, another agent, a key agent that we welcomed as an agent in the refractory setting, belzutifan. How comfortable are we going to be to re-challenge patients with a HIF-alpha inhibitor? There are more than belzutifan coming in after they've progressed on it. I mean, does that give you any pause? We have no idea. Do we use the same timelines as other things? I don't know if you have any comments on that. Does that?
Yeah, the future is going to be exciting for sure.
At least you're excited about it, right? We're excited about the
definitely.
future. There's a lot of unknown. Stay tuned, folks. A lot of trial data needs to come to help us. Well, great. So let's move back here to Neil.
Clearly, the risk-benefit proposition of the Pembro-Bel combination must consider the additional adverse effects of HIF-2 blockade.
Belzutifan is the new kid on the block, not as much experience in the community. Belzutifan has two notable unique toxicities that all patients and doctors should be aware of, and that's severe anemia requiring transfusions mediated through HIF-2 inhibition, as well as hypoxia, which may be mediated through the alveolar cells in your lungs and HIF-2 expression. And so I wonder if the panelists could talk about how they counsel patients on those toxicities, monitor those toxicities, either with home monitoring or in-office monitoring, and how they manage those toxicities when they develop. And I wonder if the expert panelists could talk about whether there are certain patients that are not appropriate for belzutifan, whether that's pre-existing lung disease, severe anemia, high altitude where you might become more EPO dependent and have high baseline levels of hypoxia, and whether there are certain patients where they're following their patients more carefully on that regimen.
I have a question on anemia. Do they use erythropoietin? Do they use dose reduction? And how best do they help maintain dose level? What is their threshold? Is it below 10 for a growth factor with erythropoietin and Procrit? And do they do dose reduction and at what level? Hypoxia, would there be concerns about re-challenge if somebody really has hypoxia, and how do they manage it?
In my clinical practice, I will always check if somebody has baseline anemia. I'll check an iron panel, B12, folate, try to understand, are there reversible causes of the anemia? Are they bleeding? Is it from the hematuria? Like, do they have a GI bleed or something going on? The other thing that I do is if they are anemic at baseline, I usually will put in the authorization for darbepoetin. It's not to say that I'm going to use it that exact minute, just to have it on deck if I need it. I may never use it, but at least it's there and I don't run into logistical barriers with administration. There's a lot of prophylaxis that can be done to prevent anemia. These are people that don't have metastatic disease and probably have a healthier bone marrow, and you can mitigate the toxicity with supportive care, EPO, or dose modification if needed. So patients generally tend to feel well.
Okay, so while our colleagues have put us on the spot here with some tough questions, I'd like to see how they answer them too, right? But, comorbidities, guys, do you consider relative or absolute contraindications the use of belzutifan in the adjuvant setting? For myself, obviously, if someone had transfusion requiring anemia, that would be an issue for me. Patients that are COPD, people with you wonder how these patients made it through surgery. They're barely surgical patients, may be an issue for the belzutifan. What do you all think? Eric, do you have any issues in the adjuvant with belzutifan?
Yeah, I would say my experience mostly started with the VHL population, so tended to be a younger, healthier group. To me, the pulmonary ones are the folks who get me most concerned. So again, if they have COPD at baseline, if you're certainly oxygen dependent at baseline, those are the ones that I would really be very wary of. As Ulka mentioned, are chronic kidney disease patients as well who may have EPO dysregulation to begin with. That would be another group. But to me, the biggest ones are the patients with significant pulmonary comorbidities. I also worry about them, though, with just monotherapy. Because a case of pneumonitis in someone with significant COPD could be a fatal event. So those are folks who I would counsel carefully, regardless on monotherapy or doublet therapy.
Ulka, University of Michigan, do you guys have guidelines on use of growth factors? Any issues with reimbursement for these?
This is definitely a new indication for growth factors. I think but we've typically been able to get them as needed. Now, of course, this experience is in metastatic disease, but I think in an adjuvant setting, you need to select out a patient who can withstand anemia to a certain extent, because you have to be prepared that, chances are the patient will drop a couple of grams of hemoglobin, and they need to have the cardiopulmonary reserve to be able to withstand that without any major traumatic events. So I think I do look at the hemoglobin levels and, 9-10 range. Some of the patients have had significant long-term hematuria from their kidney mass before they go into surgery. So there is that. You still have to do iron replacement, supplement the iron stores before you start them on therapy. But I think that is more the clinical perspective I look at for belzutifan. Having said that, the good news is that, the anemia is very quickly reversible, and it is sensitive to dose adjustment. So you're able to modify the dose and hold the agent to sort of start reversing the anemia pretty quickly. So those are things that you have to reassure the patients. It is important to inform the patients about these toxicities and really train them well, because I've had patients who've gone to the ER with hemoglobin drops, and they've insisted on doing endoscopies because the immediate feeling is, these people are bleeding, which they're not. This is a medication-related toxicity.
So I guess a practical question for Erica, as being the surgeon on the panel, is, I guess, the frequency of patients. We talked about, belzutifan and pembro not approved yet for this indication, but we talked about the necessity to really follow the eligibility criteria, try to get them started within 3 months. For me, as an oncologist, when I'm seeing it, it's very common to see patients with a 9-10 hemoglobin. It seems like to be pretty standard. Yeah. You're concerned about them dropping. You want to you want to start preemptively and start them on something. How often are you seeing anemia? When you're seeing these patients too, and your post-operative follow-ups generally? What would you say? Is there a large number of patients below 10, or that's unusual?
Typically not. I mean, okay. I would say that I see anemia much more in the cytoreductive space. So again, patients who have metastatic disease, they've got anemia as part of IMDC or Heng criteria that we know. So for most of these folks that we're talking about here, their hemoglobin is usually quite normal. I mean,
you would expect it to be normal.
Patients are having robotic surgery, robotic nephrectomy, laparoscopic nephrectomy. Their hemoglobin's 12 to 15. Okay. And again, we'd expect them to have normal bone marrows. They're going to be able to replenish within 3 months of surgery. Typically, blood loss is quite low, unless you're dealing with something like an IVC thrombus, and that's more acute blood loss, and then that's just replaced intraoperatively. So I would say in the non-metastatic setting, anemia would be much lower of a concern for me.
So Ulka, are you willing to start someone that come in to see you? It's been 10 weeks. Dr. Singer decided that he believed that Michigan was better than Ohio State.
Wow.
That
Easy there, Chief.
He was sending them up north to you, and you're seeing them 10 weeks after surgery, and you want to get them on therapy, and they're sitting with a hemoglobin of 9. Are you delaying patients to get started on the belzutifan until you reach some magic hemoglobin, or are you going ahead and having your nurse go for darbepoetin, like Dr. McKay said? What help us out?
I think at least I would run the iron levels and, see if there is any
assume they're all
replenishment to be done. But yeah, so no, then for a hemoglobin of 9, I would not wait typically, because if the patient is otherwise healthy, I think you can consider starting therapy. I don't initially approve the Darbo or whatever ESAs, but I'm just prepared to use them if I need them. So right now, in the adjuvant setting, I think it remains to be seen how much of a incentive or, clinically there will be to use the ESAs, but maybe for a patient who has significant high risk and, needs this to maintain the therapy.
Okay, one thing we need to talk about, I think, before we move on is hypoxia and expectations for patients. Clinically, I make sure my patients have an ambulatory pulse ox, and they're aware of it. A lot of them have read up on it, and they know when their pulse ox drops below 90%, we need to be considering doing something, a dose reduction or something like that. How do you handle that expectation in your patients? Do you give them that ability at home to say, hey, when you drop down, you tell them, get up and move around if it's still low, because oftentimes just moving around brings it back up. But if it's still low, go ahead and hold your pill, call us, consider dose reduction. And how does that go into exercise with them? How do you handle that? So let me throw it to Ulka, and then maybe Eric, you can.
Yeah, this is actually a big concern about patients who are, dropping their pulse ox because of exercise or activity and really high impact activity. And I usually tell them that, to probably not make any big dramatic changes in their activity level, to build up slowly if they really want to make a change. And we are at University of Michigan, we're actually going to be starting a study looking at, very monitored exercise and whether that improves outcomes in adjuvant disease.
Excellent. Eric, do you have anything to?
Well, I love the study that they're going to be doing at Michigan for that specific exercise program in the adjuvant space. I think that's a perfect thing to do. And I think this really gets back to, again, quality of life. So for me, the biggest thing is are the patient's symptoms preventing them from doing what they want to be doing? I'm certainly aware of the number, but less worried about treating the number, more worried about treating the patient. And if they're saying, look, I can't do the things that are important to me, we need to make a change. If it's just that, the machine's beeping at them, okay, we can be perhaps more lenient of that given their other comorbidities, but really understanding how it's impacting them.
Yeah, and I think for myself as I end, it's different when you're talking to a metastatic patient in the second and third line who've already been through toxic situations with their therapies. That takes someone who's potentially cured already, that wants to get back to normal life. They've just beat cancer, and you're giving them something, and now you're telling you got to watch your oxygen levels. Seems to be scary, and I don't really have a good sense yet how my patients are going to tolerate that. But let's move on to Module 3. Ulka is going to take us home here with a talk on the tolerability of current and emerging adjuvant approaches for kidney cancer.
Hi, good morning, everyone, and thank you. Really enjoying the interactive discussion today with both Eric and Tom, and thank you to the organizers for inviting me to speak today. So we're going to be talking about current and emerging adjuvant approaches and the tolerability of these agents. Now, mind you, in the adjuvant setting, this is a critical piece that you're going to use in your decision making for the patient, because not only is it risk of relapse, but if you cannot get through the patient. And as I said, in the STRAC trial, it showed an improvement, but because of the toxicity overshadowing the efficacy potentially, that agent sunitinib was not used in the adjuvant setting. So starting with the Keynote 564, this was the only study that showed adjuvant immune checkpoint therapy, PD-1 inhibition with pembrolizumab, led to both a relapse-free and overall survival benefit. So patient eligibility is listed there, and as you know, the intermediate to high-risk patient population, intermediate to high-risk was the predominant patient population, and then M1 resected was a small part. So this is the results in terms of safety now. Immune-related therapy has completely different side effect profile as compared to belzutifan, which has, other issues, the anemia and hypoxia that we've discussed over and over. With immune checkpoint therapy, these were the updated safety findings. The thing that I want to highlight is that majority of the patients, about half of them at least, got almost the full year duration of therapy. So in terms of delivery of therapy in this otherwise healthy patient population, it was not a big issue. However, about 10 to 15% of the patients, if you look at the lowest row there, the immune-mediated AEs and infusion reactions were seen in about 9.4% of the patients on pembrolizumab, as compared to 0.6%. This was a pretty unbiased reading because this was a double-blind placebo-controlled trial. So about 9 to 10% of the patients are going to get significant immune-related adverse reactions. And depending on the severity of the reaction, unfortunately, some of them are going to have lifelong side effects or need lifelong steroids or, other supplements, hormone supplements, for instance. So what kind of side effects? And here we have hypertension, AST, so transaminitis, immune colitis, and immune pneumonitis are the big threats, of course, because there is the potential for lifelong quality of life impairment, etc., and things that may be stuck with them forever. Hyperglycemia or incidence of type 1 diabetes mellitus is another one. And you can see the risk is pretty small, 1% or so, but in an otherwise healthy population, this risk does become something that's clinically relevant potentially in terms of making the decision about getting adjuvant therapy. NCCN guidelines, management of ICI-related toxicities, and this is something you have to discuss with your patients, that this is not something that will go away even if we stop the therapy. So even after you stop the therapy, clearly you would have to stop the therapy, especially for the clinically significant adverse events. However, you may need to treat with immunosuppression, such as steroids, for the first line of attack, and then, of course, going to other agents such as the infliximab and other immunosuppressive therapies may be required. And, usually we don't wait too long. Right away, start the patient on steroids. This is very much a clinical diagnosis. Ideally, you shouldn't wait for colonoscopies or, scopes, etc., to make that clinical diagnosis, and start the patient on steroids as soon as possible, and then, monitor them closely. And if they're not turning around as expected, you need to make that switch to other immunosuppressive agents. So these are the NCCN guidelines, clearly summarizes very well management of ICI-related toxicities. And there are a number of guidelines. You can use either one. Most of them very much agree and have a consensus on clinically relevant immune-related adverse events. Start early immunosuppression. So here are the NCCN, and then I have ASCO guideline updates also showing you the same thing, and you can pretty much use any of these for adverse event criteria. Now, what about patients? There's always that switch when you're trying to go from a clinical trial to the real world. And how much do you expand that indication into other patient populations, such as HIV or viral hepatitis? Now, there are small case series that have shown that, at least in metastatic disease, that in patients with HIV, immune checkpoint therapies have been safe. You can continue on the antiretroviral therapy and get, long-term benefit, again, from metastatic disease, but you could potentially use that information for the safety profile. Other existing autoimmune conditions, depending on the severity, etc., you would consider whether to use the immune checkpoint or not. Organ transplant, I probably wouldn't do it in the adjuvant setting, especially the stakes are way too high of rejection. Prior allogenic transplant, again, is very relative, because could you potentially stimulate their previous tumor, the reason they got the transplant? So I probably would not use it. And then other autoimmune conditions. So moving on to LightSpark 005 was the study that showed us and led to the FDA approval of belzutifan in the metastatic setting. Now extrapolating from that, and that established that this is a tolerable, effective agent in the metastatic disease setting, even in patients who were pre-treated previously with multiple therapies, including immune checkpoint therapy and VEGF TKI-based therapy. Median duration of therapy with belzutifan was about 7.5 months, so this is a limited experience in the metastatic disease setting. Clearly, this was a different patient population, a sicker patient population. And despite that, about 2/3 of the patients had some anemia, had grade 3 or higher side effects. So that is definitely something to keep in mind. But as I said before, the adverse events of belzutifan are actually very quickly reversible when you hold the medication and very sensitive to dose modification. So those are things to keep in mind when you know about the AEs. And anemia and hypoxia top the list. As you can see here, some of these dizziness may be symptoms of the anemia itself. There is dyspnea, there is weight gain, there seems to be a fluid retention and bilateral lower extremity edema that has been noted and reported with belzutifan therapy. So all of these side effects are definitely things to keep in mind, but the anemia and hypoxia, and we tell patients to monitor their oxygen levels with pulse ox. COVID helped us sort of with that because now everyone knows what a pulse oximeter is, which previously we'd have to start with educating people about that. What about belzutifan at high altitudes? And this is likely to come into play more and more as we use it in the adjuvant setting. You know, clearly at high altitudes, automatically people's oxygen levels, they have some hypoxia. And my recommendations may be different for somebody who's just going hiking for a short period of time where you could potentially hold the belzutifan and then resume it after they come back versus people who are living at high altitudes for a prolonged period of time. So clearly there is a small study, interestingly, that looked at the incidence of anemia and hypoxia in patients who lived at high altitude cohort. And what they found is about 88% had some hypoxia, which grade 1 hypoxia may not even be symptomatic, but grade 3 was seen in about 50%, 48% of the patients. So just keep in mind, you may have to factor that in, especially for patients who may be just moving to a high altitude level, which, would be a small proportion of your patients, I imagine. But managing AEs from belzutifan, as we've been talking about, definitely check the hemoglobin, make sure that is well robust, especially for the adjuvant setting patients. No major changes in the exercise level should happen. They should build up gradually if they're out deconditioned. And as I mentioned, we are planning on doing a study looking at exercise challenge in the patients post-nephrectomy who are on adjuvant therapy. So stay tuned for more information from that. But adverse reactions, typically if they have the event happen, withhold the dose and look into whether you want to do dose reduction or consider erythropoietin-based agents. LightSpark 022 was the study design that led to the fact that we saw the combination of pembro plus belzutifan showing effects. And again, the treatment-related AEs leading to discontinuation were this, anemia and hypoxia for the belzutifan arm. But the actual discontinuation rates were very small. And even though anemia was seen in 84% of the patients on belzutifan, so you expect a slight drop in majority of the patients, you see that the grade 3 and 4 is in a small proportion of patients. So that is what's shown here. Anemia, specifically looking at adverse events of special interest, in this case anemia, leading to interruption of belzutifan or placebo, 24.7% of the patients, and about 17% of the patients responded to dose reduction. Actual discontinuation was in a very small proportion of patients, only 4%. So again, same thing for hypoxia, even a lower proportion of patients, 1.5% of patients had to discontinue because of hypoxia. So the incidence is likely to be low. Again, this is a more robust clinical trial patient population, but when you're extrapolating to your real-world patient population, think about these things. The overall report is low incidence, but clearly with your patient, make sure they have the cardiopulmonary reserve to sustain that kind of drop. I would conclude with some core principles of adjuvant therapy. Clearly, clear cell renal cell carcinoma is a systemic disease. There is the risk of spread with hematogenous metastases, and the primary goal is to destroy those hidden cancer cells. So hopefully more proportion of our patients don't go through that traumatic relapse, because at the time of relapse, clearly the incidence of long-term remission is much lower. So risk-benefit assessment comes into play, patient evaluation, as I said, make sure the patient is healthy, otherwise asymptomatic, with a decent life expectancy where this could help them. And then evidence-based selection, which you've seen with the LIGHTSPARK-022 and Keynote 564 data. Better and better risk profiling is always good in adjuvant disease. And I will end on this note of bottom line for adjuvant therapy. The shared decision making is a critical piece. And I've summarized some of the risks and the benefits of each of the agents, whether you're using definitely adjuvant pembro, which currently is FDA approved, and then potentially the combination if we get that FDA approval. Thank you.
Great overview, Ulka. So let's move it back to Neil.
Another ongoing phase 3 adjuvant RCC study is the Alliance Strike trial, evaluating another adjuvant pembrolizumab doublet, this time with the TKI tivozanib. I wanted to see how Dr. Motzer sees ongoing research, but in speaking with him, suddenly I had a pretty intense 20-year flashback. The 2005 ASCO meeting, I remember being in the audience and watching you present the first waterfall plot I ever saw.
Yeah.
Does that sound right?
Yeah, that was right. And, the thing is, so people, they didn't have phone cameras then. And so when I was presenting it, there was like all these pop-offs. It was like fireworks going off by cameras with their phone. Yeah, I know that. The waterfall plots at the time were sunitinib, sorafenib, and I think that may have been the first one at a big meeting like that. Yeah. We created the waterfall plot. It was like fireworks going off in the audience. I never had something like that happen. It was just something, it was amazing.
Anyhow, which adjuvant trials right now are you most excited about?
The trial that I'm the most excited about in adjuvant therapy is the trial that has the messenger RNA vaccine in it, the V940. I'm sure you've heard the data from melanoma, right, where there was a personalized messenger RNA vaccine from Moderna that partnered with Merck. And so we've done the same study, and it's a large phase 2 trial, over 300 patients. It compares pembro plus placebo to pembro plus this messenger RNA vaccine. We actually send off the patient's tumor, the kidney tumor, along with the blood, and then they identify about 35 neoantigens in the person's tumor, and they embed those in messenger RNA, and it's given as a vaccine along with pembro. I think that whole idea of a personalized vaccine in this sort of setting, particularly in view of the positive outcome in melanoma, I actually think that's what I'm probably the most excited about.
So, questions for our faculty here. I'll pick on Ulka here for a little bit as she works. She leads a cooperative group's kidney cancer program. The Strike trial. What are your predictions or comments about that? Do you feel that, given that the LIGHTSPARK trial is positive, although no survival benefit, that means that other combination strategies are going to be positive, or is that wishful thinking?
I think the efficacy of VEGF TKIs has been well proven in clear cell cancer, especially metastatic disease. In the adjuvant setting, I think we haven't been able to cross that efficacy toxicity barrier, and maybe tivozanib has a chance of doing that for us because it is a much more tolerable VEGF TKI as compared to the others.
Let me ask you this. Let me get you on the record. He'll make a little provocative statement. Would you be willing to say that tivozanib is the most tolerable TKI or no?
No, I don't think, in metastatic disease, first of all, there are no head-to-head comparison trials. So it's very hard. It's only been compared to sorafenib, and compared to sorafenib, yes, it was better tolerated. But I feel like the duration may also help us in that regard, because the STRIKE trial only has 6 months as compared to a year with the previous adjuvant trials. So all in all, the good news about VEGF TKI is same thing. You can reduce the dose, you can hold the therapy, and most of the side effects are reversible. So those are some of the advantages. And I feel like we should support a clinical trial that is trying to advance the field. That is how we got here today.
Isn't that a little risky? 6 months versus a year? I mean, that seems to be, in my mind, I don't know that we've proven that combination therapy with the VEGF TKI is an established therapy in the adjuvant setting yet. And so it seems to be risky to already change the treatment schedule, the duration of treatment before you, because that's another question. It's how much can you get, how much can you buy with, how much do you need? So I'm concerned about
But the
that.
Pembro's a year.
Yeah,
The Pembro's a year.
still a year.
So everyone's getting standard of care Pembro for a year. It's just plus minus the TiVo for 6 to
Fair
see
point.
if there can be some, ideally synergy, but I'd be happy with just additive effect. In my mind, I have equipoise. I think it makes sense to support the trial. It's been accruing well, and so I think it'll be an important additional piece to what we have to offer.
Fair enough. Back to Neil.
Belzutifan has also been combined with a TKI, specifically lenvatinib, and Dr. Motzer also recently presented findings from LightSpark 011 in metastatic RCC after immunotherapy, where the combination of belzutifan and lenvatinib demonstrated a PFS advantage compared to cabozantinib. With a look to future combinations, I asked Dr. Motzer to compare his experience with lenvatinib compared to cabozantinib.
Lenvatinib has more hypertension than cabozantinib. It also has more proteinuria. In terms of diarrhea, it's probably a trade-off. I actually think there's more diarrhea long-term with cabozantinib. But what I found to be particularly troublesome with the cabozantinib is the skin toxicity for patients, the mucositis with patients. And the other thing is there's really very little liver toxicity with lenvatinib, where cabozantinib much more commonly causes liver toxicity. What I generally do for lenvatinib is I prescribe the 2 10-milligram tablets if a patient has hypertension, but I start with the one for a week or two, and I make sure the hypertension is under well control, and then I add the second, rather than just giving it all at once and finding out a patient gets quite hypertensive.
Okay, so just a quick question here, just to kind of end us, where we are. Well, we had an in-person question here I thought was interesting, just to kind of seal the deal here, and maybe let Eric and Ulka end us up with a refresh here. The question, what we're asked is, would you recommend adjuvant Pembro after partial nephrectomy for a 5-centimeter clear cell RCC grade 2 PT3A for renal sinus fat involvement only? And then I want Eric to comment on the issue related to lymph node dissections not commonly being done at the time of surgery. So have at it and we'll close.
So 5-centimeter T3 for that, again, depends. I want to know the age of the patient. So it's something that I would discuss. I don't think that would show up as being high risk according to really any of the nomograms. Certainly Assure, I don't think it would. So I would discuss it. Most likely that would be someone who I suspect they would select surveillance. But again, observation, monotherapy versus trial would be the discussion. In terms of lymph nodes, current guidelines and recommendations are, if there's radiographic evidence of enlarged lymph nodes, to do the lymphadenectomy, but it is certainly, we don't have the same level of evidence for testicular, prostate, or bladder as we do.
It's not therapeutic.
The data has not yet to show a survival advantage. I would say it's more diagnostic, prognostic. There are some small studies that did show, but in larger studies, I haven't been able to find a convincing evidence of that. But again, those may be the patients who we really want to think about adjuvant therapy and perhaps intensified adjuvant therapy.
Excellent. Thank you all for just a wonderful presentation this morning. Hope you all enjoy the rest of the AUA, and I'd like to thank my distinguished faculty here in person and the ones on the video.
Thank you.